Hello, everyone, and thank you for joining us today. My name is Barney Gill, and I help with our education curriculum here at Beam Readers. I'm excited to kick off the second webinar in a series by Beam Readers oral and maxillofacial radiologists, sponsored by Vatech America. I'm honored today to introduce Dr. Naila Baclini, who's one of our cherished team members. Our goal here at Beam Readers is to help you be successful and get the best actionable information from 3D scans you take on your patients. Dr. Baclini is one of our nearly 70 oral and maxillofacial radiologists that are experts in unlocking the information within each scan. Today, Dr. Baclini and Vatech America Director of Education Jim Mayer will have a discussion around reviewing 2D panoramic images and the transition to 3D and cone beam CT. We hope this information moves you further along in your understanding of evaluating 3D image volumes and the clinical correlations. This also gives a glimpse into the depth of knowledge and expertise that is applied to every scan we read. We're offering 1 hour of CE credit for those of you that are joining us live today. Please make sure that you stay on for the full hour and take the survey we send following to earn the CE credit. Then within a week or two, you'll receive an electronic certificate from me and our CE partners, Big Sky Seminars. To ensure we clearly communicate everything today, we did pre-record this webinar. Dr. Baclini and Jim Mayer are here online with us now to answer questions in real time, and Jim will provide instructions on how to chat with us during the presentation. If today gets you excited, please come register with us at www.beamreaders.com and see how an oral and maxillofacial radiologist can support your practice by reviewing and providing a second opinion on your CBCT scans. Also, please check out our other educational offerings on our website through the drop-down menu at the top of the page. If you have unique educational needs relevant to CBCT, please don't hesitate to reach out to us directly at education@beamreaders.com. Now let's get the presentation rolling.
Thank you, Beam Readers and Barney. A few items to discuss before we begin. The chat feature is located on the upper right of your screen. We will chat with you via email that you had registered with. Next, I would like to introduce Dr. Naila Baclini. Dr. Baclini, I want to thank you for joining us today and welcome. I'm really excited about today's session. We're going to be talking about anatomy in your CBCT, which is, making that transition into cone beam, or even if you've had your device for a long time, this is still a relevant topic.
Absolutely. Thank you, James. I'm so happy to be part of this collaboration between Beam Readers and Vatech. And hopefully after this session today, our audience will be able to more comfortably navigate through a CBCT, identifying some major or generalized anatomical landmarks.
For sure. So one of the questions is, why focus just on anatomy for today's session? I interpret it as a building block to understanding what you're seeing in the data set. What's your take on that?
So absolutely, we all want to know pathology, we want to be able to identify it, but to be able to get there, we need to know what is normal on a CBCT and what are the structures that we are actually looking at and how they look in a normal state versus a pathological state. So we have to know each of the structures that we are looking at, be able to identify it, and make sure that it looks within the normal range.
Understand, very true. So the next question that comes up is, we're going to start with looking at a panoramic image, which doctors have looked at, very familiar with that. A lot of the same structures in the pan, but what are we not seeing in the pan that we're seeing in the CBCT?
Well, on a panoramic, you can see a lot of the anatomical landmarks. However, there is a lot of areas that are not shown on a panoramic. And when you acquire a panoramic radiograph, there are so many superimpositions, and some of the structures are even projected in another location. So all the central structures, such as the C-spine, the hyoid bone, the airway, are projected bilaterally. So you are not actually seeing exactly as you see on a CBCT, the exact locations of the landmarks, the sequence, how you see them. There are no superimpositions, no ghost images. You can see all the structures from a 3D plane. So it is really a different aspect of viewing those anatomical structures.
Yes. One thing that I want to point out is that there's always distortion on a pan of
Absolutely.
the images you're seeing. But within the cone beam, a question we get a lot is this one-to-one? And really the data is a one-to-one because of that cone beam technology.
Yes, absolutely. I agree with that. Distortion can sometimes make some structures look weird, odd. You may not identify them correctly on a panoramic image.
All right, gotcha. So let's talk about an outline of what you and I are going to talk about today to give the audience, an overview. We're going to start out with anatomy and a panoramic, look at some anatomy on that. We're going to move into just a quick review of the CBCT and the three sections of plane: axial, sagittal, and coronal. And then we're going to get into a systematic review of the cone beam with a focus in anatomy. And then lastly, you've been generous enough to work up a case review of the data set we're going to be looking at, followed by we'll finish off with a question and answer session.
Yes, absolutely.
Well, doctor, let's go ahead and start with our first topic, anatomy in our panoramic. I have a panoramic right here. Let's kind of go through some common structures that we're seeing on the pan. And as we progress through, if you want to go ahead and kind of talk track what we're seeing, and we can kind of go back and forth here. But first we've identified our TM joint on the device. Yes,
we can appreciate the condyles, the mandibular fossa, and the articular eminence on that in that circle right there. The nasal septum right there, and the hard palate, and projected bilaterally is the hyoid bone.
I do get a lot of questions on this whenever I'm working with offices of what are we seeing, and a lot of them come up with is, what is the hyoid bone? What is that?
Yes, and sometimes, absolutely. Sometimes when the patient is swallowing, you can actually see movement in the hyoid bone where you can actually see like motion artifact, and the hyoid bone can also superimpose over the inferior border of the mandible.
Right. And a lot of that has to do with patient positioning and instructions to the patient of letting them know what needs to be done when they're in that device there.
Absolutely. The C-spine also projected bilaterally. Yes, the coronoid process, left, right, and left.
Well, let's move to our next slide here.
So this is the nasal cavity, and on the pan right there, we can see the inferior turbinates and the nasal air passages, right and left. So actually the right side is narrower than the left, which is sometimes a common or normal finding. It's like a physiological process, and it changes from side to side.
And we're going to look at this more in that cone beam, because we have the same cone beam specifically for this panoramic here.
The floors of the maxillary sinuses, and the right and left mandibular canals and mental foramen, which is located between the roots of and apical to the roots of the mandibular premolars. And we can appreciate also the airway, which is projected bilaterally. So over the coronoid process is superimposed the lateral pterygoid plate, which is highlighted right there. You can see it bilaterally. I left the other side not highlighted so that you can appreciate it without the lines. And we have a structure that has like an inverted triangle shape. This is the pterygopalatine fossa. And for sure on a CBCT, you can evaluate that area much more and make sure that there aren't any pathologies or anything that is, in proximity to that very complex area. And we can also see the floors of the orbits and the infraorbital canal.
One other thing I wanted to look at on here, on number 31, you can see a little issue below that RTC.
Actually, yes, 30 and 31. A common thing between us radiologists, we kind of take a look at everything on a pan or on a CBCT, and then leave the dental area to the last. And that is because we tend to focus on those areas and forget about everything else. So to make sure that we actually review all of the radiograph, it is better to leave those structures till the end.
Well, that was a review of a panoramic and anatomical structures specific to the overall view of the pan itself. And let's move on to our next topic. And so next, let's do a quick overview of the 3 sections of view within the software: the axial, sagittal, and coronal.
Okay, let's start with the coronal view. And on the software, the coronal view is highlighted with the yellow color, as you can see here on the border. And you see this line right here, this crosshair. If you move the yellow crosshair, you are scrolling on the coronal view. Now, the sagittal view is highlighted with red. It's the red crosshair that you can move and scroll through the sagittal view. And the axial view is in blue. Let's start with the coronal view. A coronal view is as if you are looking in front, if you are standing in front of the patient and scrolling from front to back, so from anterior to posterior or vice versa. So now I'm scrolling from anterior to posterior on a coronal view. And going posteriorly, and you can scroll in the opposite direction. You are still in the coronal view. Now I'm going to move on to the axial view, which is right here. So the axial view, it's when you scroll from top to bottom, so from superior to inferior or vice versa, from inferior to superior. Now I'm scrolling from the top of the scan and going inferiorly through all the structures to the bottom of the scan. And on the sagittal view is when you scroll from side to side, so from right to left or from left to right. You can scroll using these crosshairs right here, the bar, or you can also use the wheel of the mouse and scroll. It's not as fast as when you scroll through using the bars, but it depends on what you are looking at. If you want to closely look at a structure, you can use the wheel.
And you can also change the interval, or you can change your increments as you scroll through there too. That's one advantage of using that wheel on the mouse.
Yes, absolutely. Yes. You can also look at enlarge each of these planes or views. Let's say I want to look at the coronal view in a better or a clearer way. I can enlarge it. And you can also use the bars here on the side from the other views, which is a great option. And this right here is a 3D rendering, which you can look at as well. Okay.
So here we've enlarged or changed our windows to show the virtual rendering as the main screen. So for a quick review, we looked at the axial cut, moving inferior, superior. And within this software, it's referenced with our blue sectionals. The sagittal, which is referenced with the red or yellow reference lines, red or orange reference lines. And finally, the coronal, which is referenced with the yellow reference line there. That's just a quick overview of our workflow, or defining the 3 sections of view: the axial, the sagittal, coronal, and then also touching on that virtual rendering.
Okay, so let's talk a little bit about a systematic approach in how you review your scans. And this was thoroughly discussed in the first session with Dr. Al-Bukhari. I'm just gonna briefly go over it again. So it is important to adopt a systematic approach when you review your scans, and this will prevent you from missing out on structures. So just have a consistent way in how you go about a scan. I'm just going to give a little example, and there is no right way to do it as long as you adopt the same approach. So first, personally, I like to start with the coronal view, and I scroll from front to back. And on each of these views, coronal, sagittal, and axial, it's important to look at the osseous structures, the soft tissue density areas, and the low density areas or air density areas. So when you look at the osseous structures, we have to look for intact cortices, for a trabecular bone pattern, which is within the range of normal, for symmetry, for no expansions, let's say no low density areas or mixed density lesions. And then when you move on to your soft tissue density areas, We know that CBCT is limited in really evaluating soft tissue density structures. However, it is important to look for any calcifications, any enlargements, any asymmetry. And then when you look at your air density areas, such as the sinuses, the nasal passages, the airway, we have to make sure also to look for any pathologies within or anything that looks abnormal. Now let's start our anatomical review. I'm going to start with the coronal view, going from front to back. I might go back and forth or switch views for some of the structures just to make it more clear. So we're starting from anterior, and we are looking at the soft tissue of the nose. And I'm going to start scrolling posteriorly, and right here is the nasal bone. Now I'm going to focus on the maxillofacial region. Try not to overwhelm you with, base of the skull anatomy. Just make it more clinically oriented. So I'm scrolling. I'm going to use the wheel right here. And now I'm looking at the nasal cavity, the nasal septum right here, and the nasal passages. Scrolling more posteriorly, we are starting to see the frontal sinuses. And if you can look at this low density and try to trace it with me, I'm scrolling posteriorly and tracing the incisive canal right there. And this is an important structure to look at, make sure that there aren't any enlargements within the canal, or especially also if you are planning for implants in the anterior maxilla, it's good to trace it and define its location to make sure that your implant does not go through it or come in contact with it. Now let's scroll posteriorly. We're starting to see the maxillary sinuses. You can appreciate deviation of the septum right here. It's always good to look at the nasal septum to see if there's any severe deviation, if it contacts the turbinates or blocks the nasal passage in any way. Scrolling posteriorly, right there. Let's trace this canal as well. This is the nasolacrimal canal. We can also appreciate it on the axial view, maybe better. You can see it. Let's look at the mandible for a second. Let me scroll anteriorly again. Let's trace the anterior loop right here of the mandibular canal. It opens the mental foramen right here. Going posteriorly, we can trace the canal all the way. We can also look at it from the sagittal view, which is maybe easier. So we can trace it all the way to the mandibular foramen. I'm going to go back anteriorly to look at some of the other structures. Okay, so let's scroll again posteriorly, looking at the orbits right here. We are also starting to see the ethmoidal air cells. This is the left inferior turbinate, right inferior turbinate, and those are the right and left middle turbinates. Now, right there, if you see that passage on both sides bilaterally, those are the osteomeatal units. And those units are important for airflow and drainage. So it is important to make sure that they are patent and not blocked in any manner. In the midline of the palate, we can appreciate the mid-palatal torus right here. And right there, bilaterally, if I scroll anteriorly, we can see the infraorbital canals. So it is important also if, let's say, you land on one of the slices and you don't know what the structure is, you can look at it from other views, as well as I advise you to keep on scrolling. Sometimes when you scroll, you can better identify the structure. So now going posteriorly, I want to point out the Let me get to it. The greater palatine foramen or canal, sorry, bilaterally. It is important to look at those structures as well, especially if you have, let's say, impacted teeth that may be in contact with it. Let me go back anteriorly. I'm sorry, going back and forth, but there are so many structures. Let's look bilaterally at the zygomatic arches right there. Zygomatic arches. We are going posteriorly in the orbital cavities. Going back anteriorly for a second, look at the crista galli and cribriform plates on the ethmoid bone right there. I'm gonna scroll posteriorly again. And we are starting to see the sphenoid sinus right here. And right there, we have the medial and lateral pterygoid plates, the right and the left. Now we are going to look at the pterygopalatine fossa, but from other sides because it's easier to locate it. We are starting to see the airway right there. I'm going to go back anteriorly just for a second and point out the coronoid processes. Going back posteriorly, pterygopalatine fossa. And right there, the optical canals, the optic canals. Now we are starting to reach the area of the temporomandibular joints. But before that, we can also look at the airway from a coronal view. It's sometimes beneficial. You can see enlargements in the palatine tonsils on the coronal view. So we are reaching the area of the temporomandibular joints, the condyles, the glenoid fossa right here, and this is the greater ring of the sphenoid bone. On a coronal view, you can sometimes appreciate intracranial calcifications bilateral to the sella turcica. I'm going to show it on other views. Maybe it's even clearer to locate that area. You can see internal carotid calcifications at that level. Now we are starting to see the C-spine, the cervical spine, and this right here is the odontoid process of C2. So this is C2, C1, and you can count your cervical vertebra from there. Now, I always like to make sure that the external auditory canals are well developed and patent bilaterally. And scrolling more posteriorly, so this is the soft tissue of the ear bilaterally. So right there, we have the mastoid air cells. It's also important to make sure that the cells have a low density. They are of low density, and that there isn't any soft tissue densities within, which may indicate infections. Scrolling more posteriorly, we are about to reach the posterior border of the scan. We see the occipital bone right there. So this is the posterior border of the scan. We also always look for intact and symmetrical structures of the bones. Now, let's move on to the axial view. So I'm going to start from the top as well. Okay. We have the frontal sinuses. And scrolling inferiorly, you can appreciate the symmetrical aspect of the osseous structures, the intact cortices, the normal trabecular bone pattern. Scrolling inferiorly, we start seeing the orbital cavities. We also start seeing the ethmoidal air cells. We have the greater rings of the sphenoid bone. Scrolling inferiorly, You can appreciate. Also, we are starting to see parts of the sphenoid bone, the anterior clinoid, posterior clinoid processes. Gonna go really dive into that. The optic canals. So on an axial view, this is the sella turcica right there. So it houses the pituitary gland. It's always important, especially on a sagittal view where you can actually see all of its outlines, to make sure that there is no enlargement or destruction of any of the cortical outlines. Now, bilaterally to the sella turcica is where we usually can identify or view any internal carotid calcifications. Now, scrolling inferiorly, this is the sphenoid sinus. Let's trace the nasolacrimal ducts right there. So it helps drainage also from the lacrimal gland into the inferior turbinate. Right there. I'm going to scroll back up to view other structures. Okay, so we see the petrous parts of the temporal bone. Scroll superiorly, just okay, inferiorly. We can also trace the external auditory canals, make sure that they are present and patent. Scrolling superiorly again, just to make sure I did not miss out on important structures that I want to talk about. Okay. We have the carotid canals right here. We are starting to see the TMJs, condyle right here. And those are the greater wings of the sphenoid. And we have part of the squamous, part of the temporal bone. Scrolling inferiorly, the zygomatic arches. Starting to see the coronoid process, the right and the left right there. The pterygoid plates, which we appreciated on both pan and coronal view of the CBCT. We are starting to look at the airway right here. Scrolling inferiorly. Also we are seeing the styloid processes right there. Scrolling inferiorly, we can look at the airway, see if there are any enlargements or any enlargements of the palatine tonsils. Now we are seeing bilaterally the mandibular canals. Let me scroll back superiorly just for a second. This is the odontoid process of C2. Right there. You can also trace the canal on an axial view, but the sagittal view gives an easier way to trace the canal. Now we are moving to the mandible. And it's always good to look on a sagittal view for any calcifications that may be in around the cervical spine, on each side, on the right and left side, which may indicate external carotid calcifications. Right there is the hyoid bone. And it's the inferior border of the scan. We just reached it. And this is the inferior border of the mandible. Now let's move on to the sagittal view. Okay. So let's scroll through our sagittal view. Soft tissue of the ear. And the external auditory canal. We have right there the mastoid air cells. So I'm starting from the right side. The temporomandibular joint. Sigmoid notch and coronoid process. Angle of the mandible, and if you can see the inferior alveolar canal, it's really easy to trace on a sagittal view. The right maxillary sinus, the right orbital cavity. Scrolling. I look at the area of the teeth at the very end. So now I'm looking at the cervical spine right here. Now I want to point out a structure that I talked about previously, and it's the pterygopalatine fossa. And it is right here, bordered posteriorly by the pterygoid process of the sphenoid and by the maxillary sinus right here. So this is an important and complex area. It is in communication with many spaces in the skull through many canals and foraminas and fissures. I'm not going to go into details, but it's important to look at it, make sure, look at its integrity and make sure it's all within the range of normal. Now scrolling, we see the hyoid bone right there. And let's go back just a minute and look at the mental foramen. We can also see the frontal sinus. So again, if you feel lost, if you don't know what you are looking at, you can point it out here with the crosshairs, look at it from, on another view. If you don't know what this is, you can just point it right here and you would see it's the frontal sinus. And it's always important to keep on scrolling. So I'm gonna move to the left more. You can see the ethmoidal air cells, the sphenoid sinus, going more towards the midline. This is the nasopharynx and the oropharynx right here. So you can look where the hard palate is. Everything superior to it is the nasopharynx, and this is the oropharynx right there. Now, this right there is the sella tuberosica, which I talked about previously. You can see how nice the outlines are. It's smooth and rounded. We don't see any issues there. Sphenoid sinus, as we mentioned, the clivus. This is the odontoid process of C2. So this is C2, this is C1, 3, 4. And we look at the hard palate. This is the torus that we previously saw on a coronal view. And so we are here in the nasal cavity. Let's look at the incisive canal. We can also make sure there is no pathology there or enlargements on a sagittal view. The patient is biting on the bite stick right there. Foramen magnum, occipital bone right there. Let's scroll to the other side. Now, on a sagittal view, you cannot really look for symmetry because you don't see both sides at the same time. But it's a great view for so many things like the airway, appreciating the C-spine, the temporomandibular joints, the teeth as well. So scrolling to the other side, we are seeing the same structures again, but for the left side. C-spine again, left maxillary sinus. We can trace the mandibular canal, the left mandibular canal. If you are lost, you don't know which side you are on, just look at the crosshairs right here. We are here on the left side. This is the right-hand side. So always look at the crosshairs if you feel lost on which side you are. The styloid process right here. Temporomandibular joint, mastoid air cells, and external auditory canal. Again, the coronoid process and the sigmoid notch. And scrolling to the edge of the scan. So always look from edge to edge. Don't miss out on any findings. You never know where something is hidden. So scroll through the whole scan, have a systematic approach. Now, I did not follow a systematic approach when I was reviewing anatomy, obviously, but always have, a systematic way of reviewing your scans. You don't want to miss out on anything.
Perfect. Well, thank you for taking us through that. And I wanted to kind of follow up with one of the things you said about, if we're lost in the scan, you can navigate, basically, I call them the crosshairs to a certain point. So we're seeing in 3 dimensions. So if you did want to see the sella, you could actually take the crosshairs and put it right to that point, and then we're seeing it in all three planes of view, and it's even targeted on the 3D rendering right there too. So that
Absolutely,
is an
it's right
easy
there.
way to target and get our bearings, our orientation of where we're at on there.
Absolutely. And it's a great way to exercise as well. Let's say I know how the sella turcica looks on a sagittal view. Just point it out, look at it from other views, and that way you can exercise and, you know, be able to identify it without the crosshairs later on.
And that's the consistent review of the scans is the learning process of being able to identify and build on the information that you already know and then add more information as you go.
Absolutely. Yes, absolutely.
So another way to, Dr. You had showed us tracing or mentioned tracing that canal on really all three planes of view. But one of the ways to be able to view this is you can change your angulation of the your planes of view. And in this case, what you're going to do is you're going to rotate down the long axis of that ridge to be able to visualize that canal a little better in the sagittal view.
Let me enlarge the sagittal view. There we are. Yes, absolutely. You can use your crosshairs and reorient your axis along the ridge of the mandible, and you can have a better way to trace the canal. You can keep on scrolling and just trace it. Right there. The mental foramen right there and the anterior loop. And just finish it with a double click. And that way you can have your canal traced. That's clear right there.
And different softwares have different tools, but most of the softwares do have a canal trace tool within them. But that's one of the ways to visualize different structures. As you pointed out, I call it the targeting system, but also being able to manipulate the data at an angle to be able to view different structures that you're looking at on there.
Absolutely.
Well, thank you for taking us through that.
Of course.
All right, so we've just done our anatomical review of a data set, and Doctor, you actually took that same data set and did a radiology read on it, and here's the report. And let's go ahead and take everybody through what those reports look like, what we can expect, and the methodology and the overview of the report itself.
Okay, so let's start with the first section right here, is the patient information. Date of birth, patient's name, gender, everything that the provider has sent us, we just insert it right there. Now, in the acquisition method is where we talk about the field of view size, the radiographic technique. If there are any errors, we just point them out, and that way our provider can, improve their technique with time. And we mentioned how the stabilization of the patient is, if the patient is in maximum intercuspation, or if there is a bicyc, or if the patient is, if the patient is landing on a chin cup, and how we orient the scan, if there's a large field of view, how we reorient it, and the software that we are using. Now, in the radiographic findings is where we actually describe what we are seeing. So we have the dental structures, osseous structures, paranasal sinuses, nasal cavity, airway, and temporomandibular joints. And if there are any other findings like calcifications, intracranial calcifications, we can add here another section for that. And lastly, we have the impressions, where we have our maybe impressions or a differential diagnosis. It depends on the case. And we also add screenshots to explain, to make the report clearer. We always add a panoramic radiograph. We add sagittal views or, different views. Those are coronal views. I'm going to go through them in detail. And this is a cross-sectional view of the temporomandibular joints. And this is a 3D rendering. Let's go back and review the report just a little bit more in detail. So on the dental structures, I always count the teeth to make sure that we have no supernumerary teeth, or just to identify the missing teeth. Now, if you noticed on the scan, on the panoramic, number 30 and number 31, they have periapical lesions. So here I added a sagittal view showing the periapical lesions on 30 and 31. And I always like to add coronal views for endo cases, just to be able to see how many canals we have, if they are, fused, to see the canal anatomy, to look at the previous endodontic treatment, to be able to appreciate, the obturation, and to show the lesions right there. So again, I'm gonna go up. So here I described the previous endodontic treatment, the obturation material, and the lesions that are periapical to the roots on both. And then I move to the osteostructures. We always point out if there is any periodontal bone loss. We look at the cortical and trabecular bone pattern in general, the incisive and mandibular canals, if they are intact, if their dimensions are within the range of normal. I point out if there are any exostosis or palatal torus, and make sure that there are no associated pathology. Now, on the cervical spine, I'm going to go to the 3D rendering. I noticed an ossification in the posterior atlanto-occipital ligament right here. It's bilateral. And this can be related or linked to cervicogenic headaches. I just pointed it out in this section and, of course, in my impressions. Next is the paranasal sinuses. There is trace mucosal thickening in the right maxillary sinus, which is, of no clinical significance. The nasal septum is deviated. I always try to mention that, especially if it's severe and blocking the nasal airway. The osteometal units, I always mention if they are patent or if they are not visualized. Now, in the airway, the airway here in this scan is, the patient had a posterior positioning of the tongue, which made, seem that the airway is narrowed. However, I think it's just the positioning. I always like to mention that as well. Now, in the temporomandibular joints, I always like to divide them into right and left. So in this case, we talk about the condyle by itself, its shape, its cortical outlines, and the mandibular fossa as well. We talk about its shape and the articular eminence. And in the last section right here, we talk about the positioning of the condyle. However, in this scan, the patient is biting on a stick, so there's no point really of evaluating the position of the condyle. It's better to have the patient in maximum intercuspation to be able to accurately do that. Now, in my impressions, I pointed out that number 30 and 31, they have periapical pathologies, and that there is a functional remodeling in the temporomandibular joints. I also mentioned the cervical spine and the ossification of the posterior atlanto-occipital ligament. And I just mentioned that it can be, a possible cause of cervicogenic headaches.
And then I like that all the reports follow with the photos that are definitely marked up and have annotations on them.
Yes, absolutely. It makes, reading the report much, much clearer.
Right, for sure. Well, thank you for taking us through the case that we just reviewed for not only anatomy, but also for any pathologies and the overall case review of that.
Absolutely. I hope that this made things, clearer, that, when you get a radiology report, you can get so much from it. There are so many things that, if you're not trained to look at a CBCT, it's hard to, pick them up.
Very true. Well, thank you for taking us through that.
Of course.
So next, let's look at utilizing some of the tools within the software here. Doctor, you took us through utilizing the NPR for that systematic review and also identified our anatomy in the scan. We also have what's called our 3D pan tab here. And this is a good transition or a good way to review the scan, and it shows the 3D rendering. And really this 3D rendering has been flattened out into a virtual 3D pan. We do have our target window here. And the nice thing is I can just double click on an area that I want to look at. So let's say we want to look at our joints, our TM joints. I can just double click on that area and then rotate. And now we're going to go ahead and scroll as necessary. So double click, it takes us right to that point, and then scroll with your sectional slices down below. We have, you would looked at number 30 and 31 here. I'm going to double click on that area. And if I come here and I can rotate our slice here, and now it gives us those coronal views that you had shared within your report. This is an easy way to take either the patients or as a clinician, go ahead and review the scan itself, also looking at apices of 30 and 31 there.
Absolutely. And you can change also the interval.
We can also change the interval here. Yes. So we can right click down here. And if I want to change my interval, right now we're scrolling at a 1 millimeter increment. So if we go down to a 0.5 millimeter, we're now going at just that 0.5 millimeter increment as we scroll through. So it's an easy, quick way to make the changes that you're looking for. Another way to do this is we can rotate this, having the red lines horizontal, which now our sections become our axial cuts. And we can now scroll down inferior. And as you pointed out, there's our mental framing.
Absolutely.
As we scroll back up, we can start to see those pathologies you had pointed out. And now we're scrolling up superior through that tooth itself. We were talking earlier, Dr. Beckley, and you had mentioned that this is really a good view for implant planning, which we really haven't talked about today at all. But I can see that number 30 or number 19 right here, we can double click on that area. And if we remember looking at our panoramic view, let's actually go back to that. And we can see our pan right here. And from our pan, I've got plenty of space here, but buccolingual, what are our measurements there? And this is the nice thing with our pan. We can come through, and let's go back to our 3D software here.
Absolutely. If you look on the pan, you would say, okay, I'm going to go ahead and place that implant. But when you look on the coronal view right there, you see the alveolar ridge atrophy on the buccal aspect is severe.
Right. And let's enlarge those slices there, and you can really see that it is very small, or I'll use the term almost a knife edge, right? It's very small. And then that's where we could come in and take our measurements to go through and look exactly what measurements do we have in that specific region on there.
Yes, and you can also take measurements from the alveolar crest to the mandibular canal and height, just to make sure you have enough height. Well, in this case, I mean, there's a lot of atrophy there, so.
Right. And where would that be troughed off or grafted? That would be
grafted.
Yeah. That would be up to our specialists that are in the audience.
Absolutely.
We do have a clear view of the inferior alveolar canal right there, and you had traced that before, but this is another way that we can go through and trace that canal. And right now, let's go here, and I'm going to go ahead and scroll posteriorly, and I'm going to go to my nerve trace, and I'm just going to go ahead and place the point here, and we can scroll mesial and go through and place our points. So within this software, other softwares, you can do this in virtually any of the windows. It's just a matter of best identifying that canal. And I'm going to go ahead and stop right there at the mental foramen. And we can see that now we have a measurement here, or a better understanding of where the canal is in relationship to the measurement here. And if I wanted to edit that, we can always edit our canal and move that right to the center of our point there. So the 3D pan window really is a versatile window for navigating through and looking at areas. You had mentioned, another thing we had mentioned was the incisive canal or incisive foramen right here. We can see that that goes all the way through from, now we're at a more of a sagittal slice right here.
Right.
and going through different structures. Here's our, if we scroll through, we can go through and see that
spiral process.
I'll look through there. So easy way to navigate through and look at structures within the 3D pan. Another tool that you have as a clinician to navigate through your scans and look to go through your case planning there.
Absolutely, yes, I agree.
Dr. Bacalini, I want to thank you for your time today and the efforts on this project. I think it's been a pleasure working with you, and I think we've really worked to show anatomy in the cone beam and the pan to provide our users or our clients a base for knowledge of building their practice and building better dentistry for their patients.
Absolutely. Thank you, James. And I hope that our session can be beneficial for our viewers and audience to be able to easily navigate through the CBCT. And if they have any questions, we are available. Please contact us and send us your questions or concerns.
Definitely. And I want to thank everybody for attending and for those who chatted with us during today's session. Please check back for additional sessions where we will be exploring more pathology and common findings within our cone beam. And again, thank you, Doctor. Thank you for everyone attending, and have a great day.
Thank you again, Dr. Bacalini and Jim Mayer, and all of you who joined us today. We hope this gave you a better understanding of an approach you can apply to evaluating your CBCT scans and a glimpse into the expertise applied to every scan read at Beam Readers. Be looking for that survey email to ensure you get your CE credit for today. To continue on your personal journey and dive deeper into your 3D knowledge, please come give us a try by submitting a CBCT scan at beamreaders.com. Thanks, and have a great day, everybody.